We're going to wait just a minute for folks to enter the webinar and then we'll get started. Okay, I'm going to get us started in the interest of time. Thanks everybody for joining us. I'm Chrissy Giuliano, Executive Director of the Big Cities Health Coalition. BCHC is a forum for leaders of America's largest metropolitan health departments to exchange strategies and jointly address issues to promote and protect the health and safety of the nearly 62 million people they serve. So you can see our members on the screen here. Thanks again for tuning in today. I know it was a late night for a lot of folks, but we're going to power through. Just a few housekeeping issues. This session is being recorded. All lines are muted except for the speakers. You can use the raise your hand feature or chat Gabrielle Nichols in the chat box if you have any technical issues. And you can also use the chat feature to share questions and we'll get to them either throughout or toward the end of the webinar. So I'd like to go ahead and introduce our speakers today. Stephen Williams is the director for the Houston Health Department. It's a health department with 1,100 plus employees serving 2.1 million residents of Houston. Under Stephen's leadership, the department has become more visible and the citizens of Houston have been afforded a higher quality of life. He's spearheaded a number of programs with the department, such as C to Succeed, Assessment, Intervention, and Mobilization, and Project Saving Smiles. Stephen also chairs the Texas Department of State Health Services Public Health Funding and Policy Committee. That is a mouthful. And the Coalition of the Homeless of Houston and Harris County. He's an adjunct professor at UT School of Public Health, and serves on a number of boards. Prior to serving as the health director in Houston, Stephen was the administrator of public health and deputy director of Austin Travis County Health and Human Services. He holds a MPA from Baruch College in City University, New York, and a master's of education from Auburn University in Montgomery, and a BA from Huntington College, also in Montgomery. Stephen, thanks for being with us today. Dr. Wilma Wooten is the public health officer for the County of San Diego, which has a population of about 3.3 million. She's served in the BCHC leadership for 2 years now, and in January will become the chair of the coalition. Wilma has been with the County of San Diego Health and Human Services Agency since 2001, serving as the health officer since February of 2007, and before that was the deputy health officer. She's an ardent supporter of public health and has a strong interest in health disparities and equity. Dr. Wooten is a past board member and past president of the California Conference of Local Health Officers, a current board member of FAB, the Public Health Accreditation Board. She's been on the board of NACHO and was also on the advisory committee to the director at the CDC. She received her MD and her MPH from University of North Carolina, Chapel Hill, and completed her residency at Georgetown Providence Hospital Family Residency Program in Washington, D.C. She also, she completed the joint San Diego State University Graduate School of Public Health and Preventive Medicine residency with an emphasis in sports medicine. So Wilma, thank you also for being here today. Thanks. So I think we're going to start, given it's the day after Election Day, let's start there and talk a little bit about what voting was like in the age of COVID. We know in Houston, there was a lot of early voting, you know, that sort of made the news, the lines. So Stephen, let's start with you. Sort of what did the process look like? How did voting go? Do you feel like you were able to have a safe election, given we're in the middle of a pandemic? You just have to unmute, Stephen.
I thought I was unmuted. Well, you're right. There were long lines in Harris County, but that was actually the first day of early voting. Voting was controlled by the Harris County Clerk's office. That's really their responsibility. But we had a new administrator for voting, Chris Hollins, who came in and I think was very creative and offered a variety of options. Uh, when I just give you my experience in voting. There was social distancing at the voting locations. We were giving uh, hand sanitizers. There was even a finger condom, which uh, prevented you from actually having to touch the screen yourself. The long lines existed the first day, but following that, not necessarily after that. So I think that, for the most part, they did a good job. The other thing that the office did was allow for drive-through voting. It was controversial and actually challenged in court a couple of times, but it did hold. And I think a few 100,000 people actually participated in drive-through voting. So overall, I would say give it a good mark.
Great, thanks. And Wilma, your video went blank, but go ahead and answer anyway. How was voting in the county of San Diego?
Actually, voting in the county of San Diego went very well, and that's based on feedback from voters. My staff and myself worked with the director of the Registrar of Voters and his staff to develop guidelines based on the whole COVID pandemic situation. So we implemented all of the best practices from social distancing, wearing facial coverings, sanitation, hand washing. And so there was significant emphasis placed on screening, training, testing, and then obviously the personal protective equipment. Now, typically during a voting period, we bring on 200 to 300 volunteers. For this election, we had over 1,000 volunteers. So you can see that focusing on those best practices was very important to make sure that they were safe during the times that they were training, as well as on the actual day of election. Our county also created locations. Every resident in San Diego County that was already registered to vote received a ballot. So they could complete that and drop it off at the numerous locations that were identified for drop off for ballots. So again, overall, the feedback from the voters is that things went very well.
Good. Okay, let's sort of jump back to the topic of the webinar. Wilma, let's start with you. Let's talk a little bit about what you've seen over the past 9 or 10 months with regards to COVID in the county of San Diego. What did you see sort of in the spring, the summer, and now? Walk us through a little bit the trajectory of the response.
Well, probably the best way to show that, if you have the slides, is to show that first slide looking at our epi curve, if that's possible. But early on, there was not a lot of testing or testing supplies. And then about mid-June, when we opened up, we had also an increased capacity to test. But with the opening up, we saw our cases go up. And then a month later, the state imposed restrictions that decreased the number of cases. And we saw an actual plummet in cases due to implementation of the best practices that I talked about with the election. We actually made it highly recommended for certain, for particularly the elderly going out, but for certain businesses required facial coverings, and that was up in back in March. But okay, start video. I'm having technical difficulties, sorry.
You're good, Wilma, just
okay. So we had been doing that, but with the state restrictions, we actually saw a plummet in the number of cases because of the stay-at-home order, facial coverings, and social distancing practices. And then in mid-July, that was in mid-July. And then at the end of August, the state came out with the new framework, a tiered process, purple for widespread, red for substantial, orange for moderate, and yellow for minimal. And based on your case rates, as well as the testing positivity, that placed you in one of those 4 tiers. So San Diego has been in the red tier, which is a case rate of 7 or less for some time now, but it looks like we might be going into the purple tier, which will mean that some businesses will have to roll back their operations. So I'll stop there, but that's a kind of a snapshot of where we have been with actual cases in San Diego County.
Great. And Stephen, I know, it struck me this morning that you guys are in very different places in very different states, right? So Wilma is in a slightly more conservative county in a fairly liberal state, and you, Stephen, are in a pretty liberal area in a fairly conservative state. And I know how you were able to respond and what you were able to do on the ground was affected by some of that. So tell us a little bit about the past 9 months in Houston.
Well, just to give you some context, the first case of COVID was confirmed in Houston on March the 5th. And it was actually associated with a group of travelers who had taken an Egyptian cruise. The next few cases were related to that cruise. And so we were feeling pretty good about that. But then 5 days later, March 10th, we had confirmation of a case that was not really related to travel or that cruise. And so we realized that we had evidence of a community spread. Our local health authority actually worked with our rodeo, and rodeo is really big here in Houston. It lasts about 3 weeks, and had been working with them on what to do if cases increased or there was evidence of community spread. And so the decision was made to actually close the rodeo, which was really, I think, a bold political move by our health authority. But also I have to praise the rodeo because they understood what would happen if they didn't close. And so for a while, initially, we were doing relatively well because we literally pretty much closed down. And then the governor decided that he would open back up for the most part and really limited control of the local county judge. And so then June, July, we started to see cases just started to rise. There was an increase, not only in cases, a positivity rate increase, and although deaths are a lagging indicator, we saw an increase in deaths, and also our hospitalizations got to a dangerously high level. After June, July, then there was a state mandated masking order, and we started to see cases go down. But now, since August, we've started to see, a slow. Well, actually, August was fairly well, but in the last few weeks, we started to see a slight uptick in cases. And for us, our response was related first to how could we get testing in very vulnerable communities, and so that was our major emphasis. And I have to say that we had good working relationships with Department State Emergency Services Bureau and a number of local entities to ensure that we had testing. And the thing that was really curious for us is they actually depended on us for guidance as to where to locate those testing sites. And so we ensured that there was, those testing was located in vulnerable communities. We had to engage in marketing efforts, particularly in the Hispanic community. We had one tailored initially because we started to see an increase in cases. From a department standpoint, you mentioned we had about 1,200 staff people. We ended up hiring an additional 500-600 staff people, with 300 of those folks being case investigators and contact tracing. And a number of those staff really were also assigned to look at, to collect data and do data analysis to really guide our efforts, because we needed that to see where to focus our testing efforts initially.
Great. So I know that you're both doing some work with wastewater testing. So Stephen, I know you were an early believer in this. So can you tell us a little more about the approach to surveillance and sort of what it is and what your results have been?
Yeah, actually, we're really excited about the work that's been done with wastewater. And I have to acknowledge that this is actually a partnership between our department, the Houston Health Department, Baylor School of Medicine, and Rice University. Actually, our environmental scientist who works in our department full time is on faculty at Rice University. And basically, we're implementing wastewater surveillance as a tool for early detection of COVID. Basically, this allows us to really project where our cases are going to increase, because there's about a 2-week lag in what we see in wastewater and cases actually increasing. Something that's really interesting about Houston is that we have 39 wastewater treatment plants. Usually, jurisdictions have about 1 to 5 wastewater treatment plants. And so we're actually able to go down to more of a geographical level when we're looking at what's happening in the various in the various treatment plants. As I said earlier, we had a major surge in hospitalizations and deaths in 1st of June, and at one point we were averaging about 1,500 daily cases. And what we saw was that the wastewater viral load was able to really help us to indicate a positivity rate based on the specimen date. And every week we collected, samples on Tuesdays usually from all the treatment plants. But we also had the samples split into 3 parts, and they went to 3 different labs in order to ensure the reliability of our tests. And our findings had shown significant association between wastewater concentration and positivity rates. And I said earlier that there's usually a 7 to 14-day lag between what we're seeing in wastewater and what we will actually see in cases. And basically what that did was help us to determine where we were going to concentrate our outreach and education efforts and our testing efforts. We actually used that data coupled with information from testing data to determine where we're going to actually target our testing. What we're seeing now is that there are about 15 zip codes in Houston that are maintaining a relatively high positivity rate. And given information from wastewater and the testing, we were able to really develop specific materials that were targeted populations in those 15 zip codes. We were also able to engage some community stakeholders in doing some door-to-door outreach and education, which actually resulted in a lower positivity rate and case rate in some of those zip codes. They're not where we really want them to be. We've probably reached a little under 100,000 people with a direct outreach, and it was really based on the information from our wastewater. Our next step is actually to go even more granular. In the 15 zip codes, we're going to target sampling in about 60 schools that are in these 15 zip codes because they are high risk. We've also used wastewater sampling in specific nursing home facilities, in our local jail, and in homeless shelters. After we implement this, the third step is actually going to be to do this even at more of a granular level, and we're going to do sampling in manholes in all of the zip codes in Houston. The equipment is now on order. We hope to get it before December the 30th because we're using CARES dollars to do that. But the hope is that not only will we be able to track wastewater, but there are other diseases that we can actually track through wastewater. So this would be an excellent surveillance tool that we want to really institutionalize within our health department.
Training. Wilma, tell us a little bit about what you all did in San Diego County with wastewater.
Sure. So our wastewater testing program is in collaboration with the University of California, San Diego, UCSD. And the program is entitled Safer at Schools Early Alert Program, or SASE. It's pronounced SASE. But the original focus was to do a pilot with schools, 15 schools, ranging from small, medium, large, as well as preschools, middle or elementary school, and high schools. So, and the funding initially is from CARES Act funding, with continuation next year with funding from our state epidemiology and laboratory capacity funding. So right now UCSD has gone through the IRB process, selecting the schools, and then developing the entire process for how this will be done. So they've completed that process. So we're in the early stages of sample collection.
I think we're going to have you guys back in 2021 to talk more about this. We'll do a whole webinar on wastewater sampling.
Great.
Yeah, it's actually fascinating.
Yeah, I sort of chuckled the first time you mentioned it, Stephen, but it is super interesting. Okay. Yeah.
See, I'd also like to just throw in that UCSD is also looking at their student population as students are coming back, as well as SDSU, which is another local university. So while we are focused on the K through 12 population, they are also looking at college age populations, institutions as well.
Okay, so, thinking a little bit about the future, we're going to have a vaccine sometime next year, we hope. We hear about therapeutics improving, and there's also talk about the potential of new shutdowns in some areas. So, Wilma, let's start with you. In your experience, what do you sort of see as the best ways to continue to reduce the impact of COVID? And as we think about both preventing additional cases and, preventing additional deaths from COVID?
I think that's a fairly simple answer, but it is only as effective as the behavior of the populations involved. So it's really employing those non-pharmaceutical interventions, washing your hands, environmental sanitation, social distancing, face coverings, as well as staying away from large groups, crowds, and gatherings. And then most importantly, staying home if you're sick. If all of those practices or strategies would be implemented by each individual, I think we could have a greater control of the numbers of cases that we are seeing. Because we've seen it here in San Diego when the state imposed its restrictions in mid-July, cases plummeted because those things were happening in addition to the stay-at-home order. So people weren't out and about at, going to indoor, outdoor restaurants. They were just going to pick their food up. And then businesses were teleworking. So that's another important strategy as well. But with things opening back up, the risk for exposure is great. And again, we can recommend these strategies all we want, but if people do not change their behaviors, we're going to continue to see an increase in cases.
Stephen, do you have anything to add to that?
Well, pretty much I totally agree with everything that Wilma is saying. This is really within the community's control. We have a huge role in public health from an education standpoint, but this is within the community control. But I think that we have to acknowledge that there's certain people that are in circumstances that make it hard to do even some of the basics.
Mhm.
We're talking about masking up. I mean, we've had campaigns where we've actually distributed masses in certain communities. We're talking about social distancing. Sometimes housing conditions are such that it is very difficult for people to social distance. When we were talking about wastewater and increases in cases, one of the things that we saw were clusters that were in apartment complexes, and we saw that a number of people were actually living in those apartment complexes. And even in trying to do testing, there's a lot of information that we gathered from people. A number of folks were afraid to get tested because they knew that they would have to quarantine. Well, if you only have one person in a house of 5 or 6 that's working, it is very difficult for people that might be positive and feeling good to stay home, because they know if they don't go to work, they're not going to get paid. And so therefore they would have other challenges. And so I think that, our message is very simple. I think populations, folks following those, messages and instructions is more complex than we might imagine. And so I think we have to bring other things to the table if we're going to be successful. It has to be something, in addition, other supports and services to ensure that people can follow our message.
Chrissy,
Yeah. Yeah.
can I just comment?
Yeah.
Stephen is absolutely right. Assistance, particularly for those that have to either isolate or quarantine. So in San Diego, we have public health housing for those individuals that need a place to safely isolate or quarantine. Also for individuals that identify as being positive, we have provided financial assistance to support them during that time. And there are several mechanisms that we've provided. So Stephen is absolutely right. It's not just adhering to those behaviors, although that's the first step, but for those individuals that do become positive, how can we assist them in sustaining themselves during that period that they're recovering?
Yeah, so you both just touched on this a little bit, talking about people who may or may not be able to stay home, who may or may not get paid, if they don't go to work. Obviously we've seen huge racial and ethnic disparities in cases and in deaths, and which frankly many of us aren't surprised at, right? But this is sort of a concrete example of the disparities that exist in our country among people's health. So how have you, in addition to some of those supports that you talked about, how have you approached the issue, in responding to COVID, thinking about data and testing resources and sort of all the other pieces of the puzzle? How has the fact that you work in these really diverse communities affected your response? Who wants to go first? I lost track of who was talking.
I'll start. Health equity is a priority for our agency and our county. And when we were trying to identify where to place the testing sites, we looked at, we did a hotspot for the county, and we used that to help us identify locations. But we also looked at deserts, areas where there were no positive tests, but we knew that individuals that were in our priority populations were in those areas. So we used that early on. And then in late April, our agency director became the lead for our T3 strategy, which is test, trace, and treatment, including isolation. And so that has been very effective. Now we have almost 65 different testing locations throughout the county. And with the state adding a metric in addition to case rates and testing positivity, they added a health equity metric, which is looking at testing positivity in the lowest quartiles within our county. That looks at where testing sites are. So we monitor the testing positivity in that health equity, those health equity locations. And I think close to 50% of our testing sites are in those locations. So we've paid very close attention to health equity, health disparities, whatever name you want to assign to it, so that those individuals that are at the greatest impact because of their social determinants of health, whether it's housing issues of being in multi-generational housing facilities, or if they don't have transportation, they have to use the public transportation, or if they are in frontline positions, that increases their risk for exposure. So we have taken all of those factors into consideration, trying to identify testing locations, providing assistance and services from childcare, and if they become infected, housing if they are in a multi-generational situation, so that they can isolate or quarantine safely. So those are just a couple of things that we've done, focused with a health equity lens. And one last thing is regarding data. We created a space on our webpage that's data by race and ethnicity. So we have race and ethnicity data by cases, hospitalizations, death, as well as our testing sites in terms of who's being tested, and then our staffing, because we wanted to make sure that we were hiring individuals, and we hired over 1,000 new employees above and beyond the 500 already in our health department for case investigations and contact tracing. So we wanted to ensure that that population spoke Spanish, because over 62% of our cases were Latina or Latinx. 33% required assistance with beyond English. They needed a Spanish speaker. So we wanted to make sure that our employees were able to speak Spanish, not just Spanish, but other languages. So we've, I feel, done a great job at looking at that particular issue.
Stephen, anything to add to that?
Well, initially we used a strategy that focused on both access and equity. The access was related to our goal to ensure that at least 2% of the population within a given zip code was actually getting tested. And so we did that analysis and pretty much geocoded that. And then we looked at zip codes where people were more at risk, looking at poverty, housing issues, or whatever. And luckily we had a study by UT that had been done, and we did an overlay of that. And that was our first priority for locating testing sites. And after we ensured that we had testing locations in those particular zip codes, then our strategy from past that was just about equity. We were looking at zip codes where there were high positivity rates. We also mapped deaths to see whether or not that there was an overlap there, and ensure testing. I talked earlier about our doing real targeted outreach, door-to-door canvassing, not only to houses, but also to businesses within those communities, because we wanted to really influence those people that had some credibility in the neighborhoods that we wanted to reach. We have since continued those efforts, engaging local community groups as well as key stakeholders in order to help us to do more targeted outreach. We have a very extensive marketing and education campaign, hiring professionals and as well as community members to help to get the word out from an education standpoint. We are going to follow the same strategy when a vaccine is available, knowing that there's going to have to be tremendous efforts in order to ensure that people will actually take the vaccine.
So let's talk a little bit about schools. We could have a whole equity discussion about opening schools, but sort of let's take it up to a slightly higher level, and what's going on with the K-12 schools in your jurisdictions. I know you both have tens of different school districts within your city or county. But how are you guys managing that? How are you working with the districts, and are kids going back to school? Stephen, let's start with you.
Yes and no. some of our kids, our largest district, Houston Independent School District, only about 40% of the kids are actually participating in in-person learning, while the other 60%, aside from the thousands of kids that got lost in the system, are actually participating virtually. Uh, we've had a lot of interactions with the schools prior to them coming back to in-person learning, but the interactions that we've had since they've started in-person learning have actually increased because they're having uh, positive cases. I think one of the challenges with working with the school is to make them aware of what our case investigation and epi follow-up process is. If you have one positive on a school campus, it doesn't necessarily mean that you need to close that campus. You should actually do a more thorough case investigation in order to determine whether or not, it's a class or it's a whole school that needs to be closed. I have to say that the schools have been very cooperative and eager to learn. Just this week, we're holding webinars, educational webinars with 400 teachers within this region to just get them more acquainted with our process. One thing that we have determined that we really need to do is to have a hotline specifically for schools that will be manned by epidemiologists so that we can give them ongoing consultations regarding specific situations. I think initially a number of the schools really wanted a formula. If one positive, what do we do? If two positive, what would we do? Said, nah, y'all, it's not that simple. And so we're going to use that hotline to ensure ongoing consultation.
And Wilma, what about in San Diego? How have you all been working with opening schools and working with the districts?
Yeah, we have a very close working relationship with the San Diego County Office of Education. And there are 42 school districts in San Diego, including the San Diego Unified School District, which I believe is one of the largest school districts in the US. We are requiring the San Diego Office of Education to collect information from the districts and the schools within each of those 42 school districts regarding how many schools are conducting in-person learning versus social distancing or hybrid. And then that information will be collected on will be reported every 2 weeks. And then on a weekly basis, we report in a publication we have called COVID-19 Watch, the cases that are reported to the county. Also, we leverage a process utilized with Live Well San Diego, which is working with our partners in schools, are one of the 4 key partners, and we've expanded it, these partners, to over 23 different sectors, from 4 to 23 different sectors with schools. So we have K through 12 and preschool, as well as institutions of higher education. But we meet with these entities weekly or every other week. And we started out weekly. Now it's gone to every other week, so that we can convey guidance from the state, answer any questions that the partners have. And so that's been very essential into sharing information. But we communicate with our director or superintendent of San Diego County Office of Education on a daily basis almost, and are available to any and all of the superintendents for any questions that they might have. We also have a system where we have, just as the state requires employers to report any cases to the county, because many times they know about cases before we do. We are doing the same thing with schools, and we've created a web page where they can make these reports. And we are just continuing to partner with the schools and addressing any issues, whether it's related to outbreaks or if they're not adhering to some of the recommended strategies like social distancing. So we are open and available to the school districts to address any and all questions that they have, but we work very closely with them to make sure they understand the guidance from the state.
Great. I'd like to see my kids back in school sometime soon myself. So let's talk a little bit about the holidays that are coming up. You are both lucky in that you live in warm weather areas and probably can stay outside longer into the year, maybe all year. But what are you advising people about Thanksgiving and the winter holidays, family get-togethers, things like that? And how concerned are you about the impact of the holidays on with upticks in cases? Wilma, let's go back to you, and then we'll go to Steve.
Sure. Well, the state recently came out with gathering guidance, where it's recommended that you have no more than 3 distinctive households gathering together. Prior to that, there was no gathering guidance, and it was really a stay-at-home order. But even with that, coming up for the holidays, just as we did for Halloween, we're coming up with guidance about some alternative strategies for engaging your family members over the holidays, from Thanksgiving even through Christmas and New Year's. So that should be coming out fairly soon. We know that the state is developing those guidance, but we will be coming out with theirs probably before the state. And then when the state comes out with theirs, we would modify ours. But again, that's the recommendation in terms of no more than 3 households. Zoom, particularly if family members live in other states and locations, and just utilizing those alternative strategies that we've utilized for other events or circumstances. And just in general, for COVID-19, given the social distancing recommendations.
For me, I'm really concerned about the holidays, because the holidays is a time where families are used to getting together. And I know that is the case with me. For example, I've been gathering with my siblings for the last 20 years in Florida. And this is the first year in 20 years that I'm not going to be with all of my siblings and their children. And so really it's an emotional moment. And so it's not going to be easy for people to give up family gatherings, although it is our advice that you really limit your gatherings to individual households. But if you do that, of course, it is, if you're gonna gather, we would still, stick to the core advice: masking, social distancing, and good hygiene. I think that, Wilma's suggestion in terms of, doing virtual celebrations is one that is really good. And for me, our challenge is not because people don't understand it or they don't want to do this. It is because, remember, for the last 7-8 months, we have not been in gatherings. We have not been socializing to the extent that we would normally socialize. And so the messaging, I think, has to be really supported with ideas of how you can actually do safely.
Chrissy, I have a unique story to share.
Yeah.
One of our public information officers attends an annual Christmas party for years that a friend gives. And this year, obviously, they're not going to be able to do that. And instead, the individual wrote a little booklet kind of based on how the Grinch stole Christmas, and it's called How Rona Stole Christmas. And it talks about the virtual gatherings instead of personal gatherings. And when it all boils down to it, it's more than just people gathering together, but it is that what comes from your heart and sharing with friends and family. And this year it's different. but it's still you still have the opportunity to share through the virtual, whether it's a Zoom, WebEx, or whatever the platform, still make that communication, because that's what's important, is making those communication. And the little book, she sent it out to all of the individuals that she would normally invite to the Christmas dinner or Christmas party. So it's different this year. We have to do things different. But it doesn't take away from our reaching out and connecting with loved ones.
Yeah, I think that's a really important message. You know, like the kids across the country, my kids have been out of school since March, and my daughter, who was just learning to read, basically spent 2 hours a day reading with my mother and my mother-in-law over Zoom while she was home from school. And now she's like, can't stop reading. So it's this silver lining of a different experience that actually probably helped her be a better reader than maybe if she had been in school in March, April, and May. So we just need to think outside the box a little bit. We have a question that I'm going to ask you guys from a viewer, and then we'll jump to 2 of our last questions, and we'll let you guys get back to work. So what actions, if any, are being taken by your jurisdictions around creating a city or county level stockpile of therapeutics, antibiotics, vaccines, PPE, and thinking about whether or not you can rely on the national strategic stockpile in future pandemics? You know, there was a lot of concern at the beginning that there wasn't enough in that stockpile, and folks really had to spend time hunting around. So have you done anything locally? Are you having discussions about that? Is that a best practice moving forward that you need to think about it? Stephen, let's start with you.
Well, we're actually in a pretty good position now in terms of PPE, and it was quite different early on. We had a number of competing interests, but because a number of our testing sites were actually staffed by the feds, and they brought in their own PPE and material, when they left a lot of that. And so as a city, we've actually run out of warehouse space because of all the PPE that we have. And so we feel pretty comfortable about where we are. But we do have a weekly meeting, and one of the things on the agenda in the weekly meeting is really a check-in as to where we are with various items that, you know, are part of our personal protective equipment.
Wilma?
So the same thing here in San Diego. We are looking pretty good in that area. PPE is one of our trigger metrics on our triggers dashboard. We are at 70% of all of our healthcare systems have greater than a 21-day supply of PPE. So that's been a focus early on. And if there is a specific PPE issue with our healthcare systems, we have a direct line to our hospital association, our CMOs, as well as our CEOs of our healthcare systems to address those issues. But that has not been a major issue for us. We consistently request PPEs from the state, and they provide the supplies to us. And so we're doing pretty well with PPE right now.
That's good to hear. Okay, 2 more questions and then we'll wrap up. So, you know, you both have different backgrounds and come to public health differently, but have been in the field for a long time. So what would you, with all due respect, what would you say to young public health professionals thinking about, you know, how do they prepare for something like a pandemic? And, you know, sort of what did you wish you'd known, or what was the most valuable piece that you've sort of come across in your time? Wilma, let's start with you.
I don't think there's anything that I wish that I had known. I mean, it's just being prepared and getting the basic foundations if you want to go into public health. And to be quite honest with you, when I went in, went to medical school. I actually got my MPH before medical school. I was interested in population health. And then I ultimately landed in sports medicine, but I've always had an interest in infectious disease. So being in public health, I feel that every physician should have a master's in public health, to be quite honest with you. That's just my opinion, my personal opinion. And it just helps to ground you and have that broader perspective, particularly from a population health perspective and not just a clinical or healthcare perspective.
Stephen?
For me, I'm not academically trained in public health. This is, I say, my third career. First was juvenile justice, then did a stint in behavioral health, which I swore I would never leave until I got a fellowship and got placed in the Maricopa County Health Department. And then found that through experience, it was something that I wanted to spend a significant part of the rest of my life in. And every time there's been an opportunity to leave, I've decided not to leave. In terms of preparing yourself, I think it has to do with the disposition of the individual person. Through this pandemic, one thing that I've learned is patience and persistence.
Mm-hmm.
And really, you have to be adaptable, because although we have planned for pandemics over the years and run exercises, I don't think that anything except our personal constitutions and our core values and our basic academic training actually really prepared us for this. And it's really what do you bring to the table as a professional, as a person, in addition to that formal training, that I think will help you survive in a situation like this. And actually, the other thing has to do with your relationship with the people that you're working with, and supports that you have. You can't be an island and survive or even thrive in a situation like this.
Okay, so last question, and I always give my colleague Gabby credit for this because I think it's such a good question. So looking ahead, what gives you hope? Whoever wants to answer first.
I'll answer. Go ahead, Wilma.
Okay, for me, Wilma, I always feel that I can survive anything for an X period of time. When our roof over at our health department fell in January 2016, we had to relocate somewhere else for 6 months. 6 months, short period of time. But I recognize that and I constantly say this is a marathon and not a sprint. So if I can wrap my brain around the fact that, we're going to be involved in this whole process, I feel, for at least 18, maybe even beyond next year. But by the end of next year, I think we should be able to see some light, because really, we have to continue these non-pharmaceutical interventions until we can get a vaccine on board and we can see or have a herd immunity. But we know that's going to be a challenge with the vaccine. The challenge is going to be people accepting the vaccine. So, but I'm hopeful that there will be a vaccine early next year so that we can start that process. So that's what I'm hopeful about.
Somebody the other day told me, instead of saying it's a marathon, not a sprint, it's actually the Great Amazing Race.
Yes.
Go ahead, Stephen.
Except for the fact that it takes too long to say that.
Oh, yes.
What gives me hope from a health department standpoint is the fact that I have staff that I can rely on. They're not necessarily the easiest staff to deal with, but they usually comes through. And I'm really grateful for that. And I'm depending on, and I think, we can depend on science too in this case. I think that there will be a vaccine. I don't know when, but there will be one. I do believe that we have to pretty much pace ourselves though, because this is going to take a long time. But I believe in people. People adapt. And, I found myself a couple of days ago, even though I was in my office by myself, I was wearing my mask. I said, wow, I've kind of gotten used to this thing. You know, it's not the most comfortable thing. It wasn't initially, but now, I'll leave it on even when I don't have to. And I'm by myself. And I think other people are adapting too. And it's really from a psychological standpoint, accepting the fact that there needs to be a change in behavior. And behavior change is hard though. It's very difficult.
Yeah, well, thank you both so much for your time today. This is our final webinar of 2020 in our series of discussions with BCHC members about their response to the coronavirus pandemic. You can find recordings of the previous webinars on our website. This one will be up in the next couple of days too. We are thinking about what to do in 2021 and to continue to talk about the great work going on in our member cities across the country. So if you have ideas, send us an email, but also sign up for our newsletter so that you can learn more about our goings on. So thank you again, Wilma and Stephen. Thanks everybody who tuned in today. And I know several of you who've tuned into many of the webinars. So thank you all. Have a good afternoon and we'll see you in 2021.
Thank you.
Thanks.
Maybe.